Good morning, everyone, and welcome to Strengthening Community Health and Partnerships in Chicago. My name is Megan Chickrell, and I'm from the Executives Club of Chicago. We're so thrilled to have all of you here for this event brought to you by our Healthcare Forum. Our Healthcare Forum is sponsored by Northwestern Medicine, United Healthcare, and ZS Associates, and we're so grateful to their partnership on bringing this programming to all of you. So without any further ado, we're in for a great conversation today, and I am going to hand it over to Brian Walsh, one of the co-chairs of our Healthcare Forum and of Northwestern Medicine, to get things started.
Sure. Thank you, Megan, and good morning, everyone. Welcome to our virtual forum, Strengthening Community Healthcare and Partnership in Chicago. I'm Brian Walsh, Vice President of Managed Care at Northwestern, as Megan mentioned, and co-chair of the Healthcare Forum. I'm excited about our discussion today, the importance of strengthening and investing in our community health structure as it relates to our common goal to beat COVID. Thank you for joining us today. Before we get started, I'm going to remind you of a few of the Zoom features that we can use as part of our conversation today. We encourage everyone to use the chat feature throughout the discussion to share your thoughts with the fellow participants. There will be time at the end for a Q&A. You can also use the Q&A feature if you would like to ask questions of the panelists. You can also use the raise your hand function to ask questions of the panelists while they're speaking. If you use this option, we can unmute your audio capabilities and you can speak your question directly to the panel. Thanks again for joining us this morning. I'm going to turn it over now to my fellow chair, Nitin Jain from ZS and Associates, and introduce our speakers.
Great. Thank you, Brian. Good morning, everyone. I am Nitin Jain, principal at ZS Associates, and I'm pleased to introduce our esteemed speakers, starting with Dr. Ngazi. Dr. Azike is the director of Illinois Department of Public Health. And prior to joining the department in January of 2019, Dr. Azike worked for 15 years with County Health, promoting the organization's mission of delivering integrated health services to all of Cook County neighborhoods. Our next speaker is Esther Shamarella. Esther joins us as the Executive Director of Chicago Hispanic Health Coalition and a member of the Illinois State Board of Health. Esther directly provides the Hispanic community with health education and disease prevention workshops, and she currently holds a position at the University of Illinois. Our next speaker is Manzar. Manzar is Senior Director of Healthcare and Life Sciences at West Monroe. Manzar partners with systems and providers to thrive in the new age of analytics, value-based care, digital health, and ongoing M&A. Donna Thompson. Donna is the CEO of Access Community Health Network. And for more than 30 years, Donna has been at the front lines of patient care delivery. She became the CEO in 2004 and has championed a focused commitment to high quality community healthcare, saving lives, revitalizing communities, and preserving possibility of healthy life for hundreds of thousands of patients. And finally, our moderator for today's discussion is Gary Noskin. Gary currently serves as the SVP of Quality at Northwestern Memorial Healthcare and is the Chief Medical Officer at Northwestern Memorial. In addition, Gary's also a professor of medicine at Northwestern's Feinberg School of Medicine. My sincere thanks for all of our speakers, and without any further ado, I'll pass it on to Gary.
Good morning, everyone, and thanks so much for joining us. It's truly my pleasure to serve as the moderator for this morning's discussion. I'm joined by an outstanding panel of healthcare leaders in our community, and I'm confident that you're going to find this morning's program interesting as well as informative. So let's just start off with a quick round of introductions. If I could ask each of the panelists to tell us a little bit about yourself, what you do, and since Thanksgiving is coming up next week, sort of a special way that you are thinking about celebrating Thanksgiving either this year or a family tradition that you have. Esther, why don't we start with you?
Wow. Good morning to everybody. Nice to meet all of you. I think it's we are basically the big opportunity for the pandemic that we had, and I know incredible job the state is doing to try to control the pandemic. Related to Thanksgivings, I mean, I think we need to be very cautious, to be at home, praying for all of people that we like and try to minimize the meeting with the family, even if we love all of them and we want to be together, will be time for that. But at this moment, we need to take care for everybody who is in the city of Chicago and the state of Illinois. So I'm really very pleased to be sure that we can coordinate service and we can work all together and maximize the resources that we have in order not to compete with each other, but working together. So thank you so much for this opportunity.
Thanks, Esther. Donna, why don't you give us an update about yourself as well?
Good morning, everyone. It's a pleasure to be here. Well, my background, actually, I'm a pediatric nurse, Peds ICU. I know Dr. Zike is a pediatrician, so I think we're kindred spirits that way. But it's a pleasure that really over the last 20 plus years, I've been able to lead Access, which is one of the largest community health center networks in the state of Illinois and in the nation. We proudly serve probably 16 of the 20 most under-resourced communities in the Chicagoland area, not only in Cook County, but also DuPage County. And, you know, as a nurse, as I think about all of what I call those weary warriors, people on the front line every day, making sure that they connect, whether they're in primary care or inpatient. We've got so many people that feel isolated. And again, our healthcare teams are going above and beyond to really make sure that families know that they're not alone. Personally, my sister got COVID. And I think as a nurse, and someone who understands critical care, she was intubated actually for 8.5 days. It really brought home the message, everything that I was seeing on TV. When you live it, you're really in a vacuum. And you're so dependent on healthcare, the healthcare system, to be able to support the needs of the family and to be able to communicate with you as much as possible. So I pray during this Thanksgiving for our healthcare workers, and also for those families that lost cherished family members. You know, one of the things I want to remind everyone that many times people that you work with every day, they don't wear it on their shoulders, but they've had losses. And again, it's up to us to continue to support, align our resources, and really be thankful as we try to celebrate Thanksgiving, but in a way that's safe.
Donna, thanks so much for those thoughtful, insightful comments. Manzar, how about giving us a heads up about yourself?
Absolutely. Good morning, everyone. Thanks. Nice to be here with you all. Manzar Sheikh. I lead our national health systems practice at West Monroe. And as mentioned earlier, I work with health systems, both in tactical as well as longer term transformational needs, which is, if there's ever a time, I think this is it. As far as Thanksgiving goes, I just really want to echo, Donna, a lot of what you said. I'm very grateful for all of our healthcare workers and essential workers who are just keeping us going and doing it so bravely and so on and so forth. As for Thanksgiving, we've got 2 young girls, so I'm learning how to bake with them. So I think that's going to be our tradition, and we are going to stay just the family and not go out as we've been advised, and try to figure out some cool Zoom games to play with the family.
Thanks so much. And Ngazi, I know you've been messaging for many weeks about Thanksgiving. So why don't you just remind everyone a little bit about yourself and what your thoughts are?
So again, I'm Ngazi. I'm so proud to serve as the director of the Illinois Department of Public Health. I'm an internist and I'm a pediatrician, and now I get to serve as the public health director. And I'm glad that these messages are coming out. It's an incredibly challenging time. I think I've been traumatized. We've all been traumatized by this virus. And so I am looking forward to next Thursday as a day to give thanks for what we do have. And there's still a lot to celebrate. And even though we have to celebrate it differently, Thanksgiving is absolutely not canceled, but it's going to be transformed into something that looks just a little bit different so that we can really show gratitude for the people that we love by keeping them safe. And even if that safety comes in the form of staying a little bit away from them physically. So I'm glad that that message is taking root. We're going to continue to push that out because I think there's still some plans that may need to be changed in some households just to make sure that that Thanksgiving Day really is a day of celebration and won't be the beginning of any problems for the future weeks.
Excellent. Thanks everyone for those introductory comments. Let's start at the beginning. We're all now functioning in COVID time, and think about those early months in the spring and in March and April. And what was the initial plan of action for your organization? And then as you began to realize that there was a pandemic occurring and there were going to be widespread lockdowns, and how are we going to actually manage things, and perhaps your top 1 or 2 priorities as the pandemic began? Manzar, why don't you tackle that one first?
Sure, happy to. No, I think I remember those days. It was definitely a little bit of a shock. And one of the things I'm very proud of at West Monroe is one of our values is social responsibility. And we have something called the 1+1+1 program, which is 1% of our talent, treasury, and time we invest in local communities. So this was a perfect time to invoke that. I went to my leadership without hesitation. Leadership said, go help the hospitals, do what you need to do. And we just went and said, what needs to be done? And we did everything from tactical stuff to helping with percentage of premium contracts, to helping collect revenue cycle AR, and sometimes even just helping with basic clerical stuff. Basically, the idea was, let's just be there and help. And we wanted to feel a part of like the frontline workers that we're actually helping. We didn't, I mean, I'm not a doctor, I'm not a nurse, but I wanted to do everything I could to help, help the frontline helpers. And that's what my team did. So that's what we did. And some of those tactical things like the percentage of premium, for example, is something that have carried a lot of systems through during a difficult and turbulent sort of financial time.
Thank you. And Donna, what were your thoughts early in the spring?
Well, I'm pleased and blessed to have a great team. The number one was around employee and patient safety. And, during those early months, PPE was a big issue. I know Dr. ZK would often talk about that. And so we also knew that the communities that we serve were also starting to get hit the hardest. And so we wanted to be part of the solution of testing. And so even trying to make sure we weren't competing with hospitals, again, my background is an ICU nurse. I did want to compete with that ICU nurse with supplies. But once we were able to secure supplies, then we were really full bore in how we could set up testing sites. We quickly went remote with our administrative teams, and we really kept our health centers open. For many in the community, a health center represents more than where you get your primary care. It's that safe haven. It's that place you trust, and trust those that will give you the right advice to help you navigate. For many of our patients, whether they're first generation, they're essential workers, there could be language and literacy issues. We knew that we had to keep our doors open to really make sure that we connected. And then as it went on, we knew that getting on telehealth was really the best thing that we could do to keep that engagement. So we quickly pivoted. Our IT teams with our clinicians quickly ramped that up. And by April, we were getting many of our patients connected and engaged with their providers.
Thanks, Donna. What are your thoughts, Esther? What were you guys thinking about early on in the pandemic? Esther, you're still on mute.
I'm sorry.
Oh, no worries. Thank you.
My background is in mental health, but I really believe strongly in how we empower consumer. So from the beginning, before the beginning, I work a lot with the chronic patients that I like to be in contact with them. In the clinic who I work, some in University of Illinois and Lower West Clinic, I was trying to communicate with the patient from the beginning to be sure they have every assistance they needed, because I strongly believe what is a community the healthcare system. So to communicate with them, where they was doing what we recommended, because they trust what we're doing in the community. For me, empower consumer for prevention is absolutely important. So if I was continue communicating with the community health worker, with the patient from the beginning that we closed the system until now, to be sure that we assisting them with the pandemic. If they need only one patient that he was expecting transplant, we was able to assist, he was recuperated. But people need the one-to-one relationship with the consumer and be sure that we assisting them with the multiple problems they have in the healthcare system. So I'm like to work with the grassroots groups to be sure the community, particular minority community, have the assistance they needed.
Thank you. And then Ngazi, I left you for last because I can't imagine anyone had a more interesting perspective as we were moving into this novel coronavirus pandemic than you. So what were you thinking about back in March and in April? And Ngazi, you're still on mute. You're still on mute. Thanks.
No, I'm on mute. I sound better on mute and I'm less controversial. No, what always strikes me when people start talking about March and April, I'm like, you guys were late to the party. We had our first case January 24th. I was in the hospital with that first COVID case in January 24th. But yes, as Donna said, it was really, it was testing and PPE in the beginning. And there were so many policy shifts and changes and pivots just around that. If you can recall, we had no ability to even test in the state when we started to have our first cases. And so every single sample had to be sent to the CDC. There was an incredible backlog. It took more than a week, 10 days, 2 weeks waiting to get results. And so it was a big game changer in February when we actually were the first state in the country to be able to develop in our public health lab the ability to test on site. And that allowed us to identify cases much quicker. But still the supplies, the reagents still had to come from the CDC. So there was still a limitation in terms of who could be tested. And so if you remember, there were so many shifts that if you were around someone who had COVID, you don't need to get tested, just assume you have COVID and stand down. If it walks like a duck, quacks like a duck, it's a duck, and then we had to shift as we started getting more testing supplies and say, no, come and get tested. So it was really quite a whirlwind there. And then the PPE, most of our PPE came from China, and China had closed a lot of production. And then when they were able to open it up, they needed it for themselves. And so we were fighting against other states, even against the federal government, to be able to get shipments. We'd make a deal, have a plan to have it delivered, and then it would be intercepted sometimes by the federal government. So it was quite a frantic time. Primarily in that beginning, it was all about PPE and testing. So it's so exciting to look back now where we are averaging almost 100,000 tests a day. People can go and get a test at one of our community-based testing sites. We also have, of course, the hospitals and other many community partners that are engaged in this important effort. We've then moved on to contact tracing and just putting all this valuable information on our websites where everybody in the state is following along and keeping up. Everybody's an epidemiologist and a public health specialist, which is great to have so many people engaged in this important journey that we've undertaken.
Thanks so much. Donna, when you think about the pandemic, it clearly has exposed some both strengths and opportunities in our Chicago healthcare community and our community infrastructure. From your perspective, what do you think that we did well, and what are some of the things that you think we have an opportunity to respond better to?
Absolutely. Well, I think one thing that the pandemic has really highlighted is the unevenness of so many under-resourced communities. And so when you think about the pandemic, it's interesting when I talk to patients and say, are you as alarmed around the pandemic? I've had some communities to say, you know what, Donna, violence, issues around trying to keep my job, food insecurity, not losing my housing is really more top of mind. And the pandemic goes kind of way below that. And so a lot of it has to do with how we're going to continue to invest in the needs of communities that have had a legacy of being under-resourced. Now, with that being said, I think from the business community, I think IDPH, City of Chicago, and I think has really started to look at the issues, people use the term social determinants of health. And we have to equally look at those issues as we're taking this journey through this pandemic. Also understanding, and as Sister talked about, people with chronic disease. People are still getting sick and dying from other issues. And so it's going to also be important that as healthcare entities that we stay aligned and really make sure that we're doing a lot of the outreach we need to make sure people stay connected around their healthcare needs. And then third, around behavioral health issues. I think, again, really right now, even from healthcare workers, for everyone, I say even the most even kill people are feeling this punch of the pandemic. And to really make sure that we incorporate resources. I think, again, there's more alignment in the healthcare community, more sharing of best practices, and more understanding of just what this legacy of historically neglecting under-resourced communities have done has resulted in some of the worst health outcomes.
Thanks so much. And Ngazi, I'm sure you have a really interesting perspective on this as well. What do you think as a Chicago healthcare community, did we do well? And perhaps something where we need an immediate change?
Well, I have to stop going after Donna because she keeps taking my answers.
Okay.
I think the challenge and the strength are tied. In general, there are issues where, hospital systems think of themselves as competitors. And so that thought of, being, who's going to get the market share, there's that normal tension when you deal with different hospital systems. But we overcame that very quickly for a common goal. And instead, we're working as partners, trying to figure out where the patients could go to get the help they needed. And so that was like a wonderful transformation that we saw happen just instantaneously to accommodate the need. I will also say that as soon as I think I was talking to legislators about immunizations and how that was so important, and people were pushing back. People don't want to be told they have to take these immunizations, and that was the talk when we were talking about school immunizations. And then in the next breath, the same legislator would ask, well, when's the COVID vaccine coming out? And I was a little thrown off, but I just think, we spend so much money and effort and time and resources, on treatments and cures, and we don't spend nearly enough time on prevention. And I think that's really one of the major takeaways. If we had a culture of understanding, an ounce of prevention is worth a pound of cure, then we maybe wouldn't have these violent, defiant objections to cloth as a preventive measure to help prevent, significant illness, morbidity, and mortality. And so I think going forward, we have public health and all of our partners really have to really dig into how we're going to, of course, public health, that's always been our thing, but we have to have that be a more systematized, unified approach, that we're all in on the prevention approach and looking for that as our first options for defense.
Great, thanks so much. Manzar, maybe you can help us with this. Clearly, the toll of the virus has been significant, and as we've heard in some of our communities, really quite devastating. But we have been able to see some bright spots, and it does give us some hope for a stronger, more connected, more resilient community when it comes to healthcare innovations and partnerships. Can you share an example of a collaboration or innovation that resulted from our local response to COVID?
Yeah, I think Dr. Ngazi and Donna touched upon it a little bit. I think that initial competitiveness, it was really overcome quickly. And I think people started to see there's a bigger picture and bigger mission. And one thing I am always personally inspired by is the orientation towards mission. And most health systems have actually taught me, like, we've heard the term like, hey, no margin, no mission. But actually I've learned that, when there's no mission, there's no margin either. And they're mutually reinforcing elements. And I think that those two elements really came live. It started to show up in the form of just people pouring in, people from all different areas, clinical, operations, technology, data and analytics, just all trying to figure this out together. And it really like hit on that DNA of us, where we want to make a difference in the world, sort of thing. I was blessed with the team that did that. And we had a few innovations in the beginning, although now they're obsolete. Some of them are obsolete. One of the ones was in conjunction with the Terry Group, we had created a website because there was just not a lot of information available. And there was not one place to go to other than Google. And we tried to create a regional website where there were some testing sites, and every time there's a new testing site, it would get updated and just have some basic information about where to navigate to, where is the online diagnostic that I could take, and things of that nature. So that was one of them. But I think the bigger one had been really around the collaboration and cooperation. There's limitations to that. I think when it came to data sharing, we certainly noticed the competitive forces kind of coming up, and there was a limit to which the data would be shared. But I think some of those coordinations, data sharing, information sharing, and things of that nature were very, very helpful, and I think remain helpful till today.
Great, thanks so much. Esther, not only are you the executive director of the Chicago Hispanic Health Coalition, but you hold a variety of advisory roles advocating for the Latinx community within Chicago. You also have the unique position on this panel by your specialization in mental health and community support. Can you tell us more about your work to address the psychological and emotional aspects of this pandemic?
Yeah, very big problem. But I wanted to say one thing, because Dr. Ngazi, we're talking about prevention, and I think we need to engage more the consumer. I think what we're learning from this pandemic is that we need to be prepared for continuous pandemic. So the preparedness is how we reach the community, not in the crisis moment, but always to engage people and engage the consumer in the process of dealing with the pandemic. I think the mental health is an issue. People have overwhelming. We discussing the job, the lack of food, the losing jobs, how they get money to survive. So when I say talking to the community, people need support. And we need to have, we can call block to block. How I think in this forum is to how each of us is in one place to maximize the resources, how we reach the community, how we are there. Is the representative, is the alderman, is the healthcare system. Sometimes we talk between us, but the consumer is totally out of the scene. And we say in mental health, we're talking about more integration with health and mental health. I think if we separated the substance abuse, the health and mental health, and I believe integration of health and mental health. The majority, 97% of the problem are in the brain, and we need to solve this. I'm not a doctor, but this is what I say as a counselor and directing in Pilsen mental health centers. So one of the things is people have the prejudice about what is to mental health issue, more than thinking that it's like a diabetes. So screening people when they go to the center, and I imagine Donna is doing that in the access service, that people need to be screening by depression, by anxiety, and in the same place that you go, get in there the service. I don't believe in separate service outside the healthcare system. I think the Federal Qualified Health Center need to have the mental health system as a part of the care with the people. So we can solve a lot of problem on violence and substance abuse. But it's a lot of work, and I want to deal with technology we can discuss. I think we need to have an application on the phone. People use the phone a lot more than going to internet. And to have message from the state or have message for the doctor. Be using like you reach any restaurant, any mall, anything, can be the same thing, information in the hand of the consumer. I said my mantra for the consumer is you capitalize your body. If you don't take care of yourself, nothing will happen. So I think more and more we need to engage. That's when I said health promoter. I said the Tupperware model, where people talk in the community about the healthcare and go to the grassroots people to be sure constantly how they get. It's desperate when I hear people, they don't know how to get access to mental health, what to do. If you have a problem, I think if the team the city is doing, the police system, working with the mental health, but they need to be a team. They need to be formed by the organization, like Access working with the police department in each community. I think if this is an opportunity to sit together, the state, the city, building Healthy Chicago 2025, and the provider, and see how we go in block to block in the communities to be sure that we are there working with the community right away. I mean, that's basically, I think we need to go back to the communities. Each community is different. Each community has different needs. And that would not, like Dr. Ziki, you said, we come with a prevention and a campaign, and spending money in the moment of crisis. We need to be in a mood in the community constantly for what are the needs of people, housing, food, whatever. So this is my idea that mental health need to be part of the Department of, I don't want to integrate the health department with the Department of Mental Health, but I think that we talk in the state about this and we need to implement that. So that's what I say, mental health. We are still not talking about mental health. I think in this culture, we know a lot of health and we promote health, but no mental health. It's still a stigma, and that is a big problem. I don't want to talk about the big things when we need to be sure that we know what means mental health for people. Actually, in this pandemic, what happened, the problem of the crisis sometimes go to the mental health issue. So this is my comment.
Esther, thank you so much for such a detailed and comprehensive explanation. That was really great. And Ngazi, I'll ask you this question so you don't have to follow Donna this time. Clearly, you've been an exemplary leader within the state of Illinois. It's really been an unprecedented public health challenge. But of course, our state is really diverse, different population densities, different workforce sectors, of course, different public opinions on preventative measures. As we approach the winter, what do you think are our biggest challenges?
So I think, yes, I appreciate this very significant diversity in our state, from rural to urban to suburban, all the different kinds of communities, farming communities, people working on the front lines with transportation. But it still is going to boil down to behavioral change. And that's always been a hard thing. That's always been part and parcel of what public health does, whether it was getting adoption of people wearing seatbelts, not smoking in public places, even not drinking and driving. All of these things are just, commonplace. We don't even think twice about them, but they were seismic shifts during that time. And so we have a new big earth-changing change in terms of trying to get people to wear masks and to avoid group gatherings and to have Zoom weddings. So this is another seismic shift of a different flavor that we're trying to permeate throughout all sectors of our diverse state, overcoming some of the mixed messaging that has made it harder to get that message through. But it really still comes down to these measures that people have to take on. The idea of quarantining and not being able to go out when you're not even sick, but that you were exposed to someone who had the virus. Again, these are all behavioral changes that, sometimes behavioral change is hard. It's one of the hardest things. So slowly, I think we are coming to the place where we need to be. I'd love to be able to push a button and expedite it, but slowly but surely, I think we're getting to where we need to be.
Great, thanks so much. And just a reminder for the audience, if you have any questions from the panelists, please put them in the Q&A section and we'll start getting to those in a couple of minutes. Manzar, here's a question for you. You've been involved with regional hospitals as the COVID shutdown occurred. And can you tell us a little bit more about that? And then also, you alluded to this a little bit earlier, but what do you think COVID exposed for us in terms of an infrastructure that can help us to more effectively serve our communities and the patients?
Yeah, no, great question, Gary. So as I mentioned earlier, I was blessed with having the value of social responsibility. So my firm and we could kind of go and again, our purpose DNA really got activated at that time. So we went out and were able to kind of do a lot of pro bono work for hospitals. One of the ones actually, Esther, you mentioned this, one of the things that we ended up doing was actually integrating behavioral health with primary care. And there was a very intertwined ability to, when you do an intake of a patient as a primary care physician, to have certain markers to notice what their behavioral needs are right now, but more importantly, what they could be, given the pandemic. So that whole integration was a very deep clinical integration. That was very helpful, and I think it changed the minds of both the mental health folks as well, the behavioral health doctors as well as the primary care, and it created a more integrated healthcare. And I think Dr. Ngazi, you mentioned as well the need for guiding the patient. Well, you didn't use those words, but it's something about patient engagement and really guiding the patient. So that's a lot of what we ended up kind of working on in terms of digital work. And by the way, when I say digital, just a little bit of an aside, digital from our perspective is not IT. Technology is a different type of capability. Digital is a very different type of capability. It's less to do with technology, more to do with humanizing the engagement and creating an experience that really matters. As far as what it exposed, I think that's a good question in terms of the infrastructure. I think there's some things that are exposed that are obvious and some things that are not so obvious, right? I think the obvious things are, we need more coordination among health systems. We need to be more collaborative. We need to share data more. We need to have the ability to react to spike demands, right? Because that's potentially going to happen, not just here, but it can happen anywhere, right? So I think those types of things are more obvious. The not so obvious ones, I think what we're finding is the geographical boundaries that traditional health systems have thought about, they're less rigid. I kind of imagine a map with all these, counties and things like that. And just imagine taking some Aquaphor, Vaseline, and just kind of smudging the lines a little bit. That's sort of what's happening, right? A lot of patients are coming in from further distances, people are moving, so all those types of things are happening. So traditionally, health systems would look at real estate and location as a primary driver of their strategy, and at least one or two others that I've worked with now, they're almost flipping that strategy and saying, well, in the future, most of these experiences are going to be remote and digital. How do I design my real estate to actually match the needs of the digital and remote kind of experiences that people will have? So that's a not very intuitive one, but I think it's a very important one. The other one we saw was there's a deep need by the patients, and I think Dr. Ngazi, you mentioned the behavioral change, right? There's a deep need by the patients. One of our clients actually did a survey during this time, which I thought was very timely, and found out that the community is really craving almost on a daily basis some guidance and some education. Is it safe for me to go out? Is it safe for me to keep my appointment? Should I push off all my annual wellness visits till later? Is that really that critical? People are wanting not just a place where they can go answer their own questions, but some sort of guidance and some sort of a guided experience. And that's where I think a lot of that digital stuff kind of comes in, because digital is less about putting up a website and having people come there. It's more about knowing how to engage people and using data and analytics to know what type of interventions will work with what type of population. I think Esther said every population is different, right? So this is something that I think was really critical in keeping the critical appointments as well as prevent cancellations. And the other one that I think is not so obvious is what I call brand promise, right? So I think a lot of regional hospitals believe that they have a brand, but I think few I'm starting to see are really emerging to have a true brand promise that can be felt and experienced by the patient. So an example of this would be, actually, it's not in our region yet, but I think Providence is a good example. They have literally know me, care for me, ease my way. That's so easy to understand, and it speaks to me as a patient. I can grade you on how well you know me, how well you care for me, and how well you ease my way. So I can tell you if you met your brand promise or not. Most of the brand promise I think I see is more about the system and what quality and things of that nature that patients are really rather less educated about. So I think that's the brand promise could become a not so obvious thing. And lastly, I think the big opportunity for health systems is to actually define the payer-provider collaboration. That's one collaboration that we haven't seen take off as much. And I actually think usually the health systems are a little bit on the reactive end and receiving what the terms are, versus I think they can actually help define in a collaborative way and design those types of benefit structures and have that opportunity to really work together to improve health and control cost, because both of those are very, very important. In fact, I worked with a few systems during this time, and if it weren't but for their ability to have percentage of premium revenues, they would have become insolvent. So in a way, having a diversified revenue and financial portfolio really helped them during COVID times. And it's not only for value-based care. I know everybody talks about value-based care. It's very reactive in many ways, but it can also help on the fee-for-service side. So I think the opportunity to transform our health systems have been accelerated by COVID. Not all needs have to be addressed in the public realm necessarily. I think there's a public-private partnership as well. Many of these can be addressed by the health systems with their local communities by keeping the health system solvent. It's a question, again, of whether the systems will really be able to combine mission and margin and purpose and profit and work on those things as mutually reinforcing ways to both serve the community, the patients, and ultimately themselves in the region.
Great, thanks so much. And Ngazi, there's a question here that came in for you. I think this person was responding to your initial comment about the first case in Illinois being on January 24th. And this question relates to, do you think we had coronavirus in Illinois prior to that date? And perhaps how far back may we have seen the first case, but it wasn't detected?
No, that's a great question. So definitely, I should say that was the first diagnosed case in Illinois. We definitely would suspect that there were other cases that were not identified that maybe didn't require hospitalization. How far back did it go? That's a little bit tougher to understand. I know it was what we first heard of it was that China identified it in maybe late November, December. So, I mean, was it there even before then? I mean, we know that there are so many flights between China and the US. So it's hard to exactly say when it first started, but for every case that we diagnose, we know that there are multiples more that were not diagnosed. It's not that every person presents for testing every day for us to know exactly all the cases. So what we know are the ones that had the test and were identified. But yes, there are more, and there were probably more before that January 24th.
Great, thank you. Donna, here's a question that came in. This individual wants to know, how will COVID strategies and policies that have impacted our health system change things following the resolution of the pandemic?
Great question. The majority of my patient base are Medicaid recipients, and prior to COVID, we could not get reimbursed for telemedicine. And so one of the things we didn't do was use our resources to hurry up and incorporate that as part of our primary care engagement. When COVID hit and it was evident that we needed to pivot, it was all hands on deck. And I think for many community health centers and others that would not have gotten reimbursed, it was almost that panic of, we've got to really make sure we engage our patients. Out of that, our patients really have gravitated to telehealth. And that's one thing that I hope that we can continue with. I think, again, from a consumer standpoint, people being able to talk to their provider at 7:30 in the morning or 7:30 at night. They're not having to get out and, do that traditional primary care visit, even though it's important. It's not going to be the panacea. It's still important that you have those healthcare visits as needed. But for many, that is something that as a consumer, they want. The big question, and I go back to what Manzar says, is as we collaborate with our MCOs, will our reimbursement be the same as a primary care visit? He's smiling, because that's something that we're strongly advocating. And again, it goes back to some of the things that Esther's also saying, that a primary care visit isn't just with the provider. Many times I say it's the supportive cast of your behavioral health specialist, a lot of your case managers, your navigators, to really make sure that that is a robust visit and that we really can use the time with the patient and their family to really hit on the key issues that might challenge them from really seeking optimum wellness.
Thanks, Donna. Esther, you previously talked about wellness and the community, but we're starting to hear more and more about the impact on healthcare workers. And Ngazi talked about shortages of healthcare workers and their well-being. Do you have any recommendations for the well-being of some of the doctors, nurses, respiratory therapists, and all the other caregivers who are involved with this pandemic?
Yeah, well, I have different recommendations, Manzar, Donna, and Dr. Zizek. I think this is an opportunity to rethinking about how we're dealing with the consumer. We wanted to consumer. I mean, if we discuss cancer before, nobody want to touch the breast, this and that. Today, the consumer are asking about clinical trial. So the more we educate consumer, the better we'll be having healthy community. So the issue to get my phone and say where I can go near to me, because we can go to any restaurant near to me, but not the clinics, with whom I can talk. I think we need to use technology and better friendly in the healthcare. I think we are new in that. We have sometimes old models, but I think it's one of the issues, and Donna mentioned clear, is the reimbursing. Who will reimburse? Community health workers, most of the time, are funded by grants. And the idea is to integrate the consumer, the health community worker, whatever you want to call it, next to the doctor, so the patient recognize who will call them for just case tracing in case of COVID, could be for diabetes. I mean, we need the pandemic not only start here. I was concerned about the chronic disease who has been affecting the COVID-19. So we need to improve the quality of care that we offer to the patient, particularly in minority community and rural community, who can help them to navigate the system and have the service. Talking about the health insurance, all these things, they are no motivating prevention, or could be, we can discuss is reimbursement for that, but we need to have incentive for the consumer to follow the regimen. So I think this could be an opportunity for future discussion between the providers that we're having here in each community, how to reinforce the well-being of people in community. And I said, Illinois having a lot of problems in rural community and funding. And Dr. Zizek, I wanted to say something about Office of Minority Health. We wanted to be funding Office of Minority Health to organizations who are dealing with minority. I mean, federal qualified health centers who the majority are minority community and not people who they don't know the community. So more and more, and this is not criticism, but it's an idea to, sometimes we are in our idea. I like to learn from the community. People, different communities having different way to deal, not only the Spanish, the African American, the Muslim community, the Chinese community. It's so diverse, Illinois, that we need to be sure that we trust us with the message, because the problem is trust. People can die, and you hear from the news that they're still dying and they don't think that they have COVID. So what happened is, of course, it has been politicized, the concept of public health, but public health need to have a good position. And this, I mean, you hear economic issues, but we need to respect the people who know healthcare and how we need to deal and avoiding politicization of the concept of healthcare. So I'm excited for this meeting. I think it's good to, Dr. Ziggy, to have a meeting called for the planning and be sure that I think a community has their own things to say. Donna, your community, what you serve, listen to you, listen to people who are hand-on in the community with the expert like Manzar that can sustain and help this, because The bank system is very good. You are in any part of the world, you touch your password and you get the money. We need to be in the same pace on the technology for helping healthcare and coordination. I started many years ago a directory, who can serve maternal child, who can serve cancer in the community with University of Chicago, Northwestern, name it. Never I find who can put all these resources in a way technological that people can press the phone, use the Apple or whatever, Android, and get what they needed. So it's like you want to buy something in Amazon and you get it. And we need to get the same thing technology for facilitate this for consumer. The consumer is desperate. They don't know what insurance to use, where to go for things, to whom to listen. I mean, these people are really, really lost in the community. So we need to pay attention to that. So that's my preachers. I'm
Thanks,
excited.
Esther. And guys, there's a question that came up that I think relates to more like active surveillance. And the question is, do we have any plans or any thoughts to be doing more surveillance testing within our communities that could help us to identify where the virus is more real time?
So we are actively working on a surveillance system. It's actually up and running. We're trying to make it more robust. We have a technology solution that's happening at different sites throughout the state, where we have a selected few that meet a certain criteria that have to respond to some specific questions. And when they find that group, I think we have about 300 to 400 a day that come in, and those are being fed to the scientists and the modelers who are, churning all of that data, trying to really build up our surveillance system. Of course, we're in the midst of it now. The surveillance system is supposed to give you a little heads up that, oh, something is coming, something is here. So this is going to be for after we get out of this surge and get back to lower levels, that we would have some kind of, indication that something might be building up again. So that is being developed, and we're getting more and more input and data into that, so that it'll be ready when we're actually not in the acute phase, that if something should come to maybe form a third wave, that we're ready.
Thanks. We're getting close to the end of our hour, and I'd really like us to end on a positive and optimistic note. And Donna, I think I'm going to ask you, as we approach a Thanksgiving holiday, tell us about something that you're really grateful about within our Chicago healthcare community, and something that gives you optimism as we're looking forward towards the future.
Absolutely. Well, first I'll start with my team. I'm very, very grateful that we have not lost any team members. I pinch myself every day and I give thanks that the people that I work with day in and day out that are so committed to the various communities that we serve proudly come to work every day. And again, we've not lost any team members. I think, again, in the Chicago ecosystem, I think everyone is hearing what Dr. ZK is saying, that, Thanksgiving is on. But again, we really want to make sure as we go through Thanksgiving and the other holidays through the first of the year, that everyone that started out with us is still with us after those holidays. And again, I love what Manzar is talking about. It really is the challenge of bringing family together in a different way, being creative. I know personally, I'm cooking more than what I've ever done. My husband is even going like, "You're cooking again?" But I think, again, it's our opportunity to embrace this journey together, use science as the basis for making decisions. And again, it's so very, very hard not to be able to hug people. I'm a hugger, and really show, how much you care about people. But again, thank goodness for technology, FaceTime, Zoom, Teams, that we can still connect in a different way and remain safe.
Thank you for ending on such a thoughtful and optimistic note, Donna. We're at the end of our time. I'd really like to thank all the panelists really for a spectacular discussion. It was really awesome. And I'm going to turn it over to Craig.
Hey, thank you very much. I appreciate it. Good morning, everyone. I'm Craig Bartholomew, the Executive Director at Illinois for United Healthcare and a fellow co-chair of the Executives Club Healthcare Forum. This was a wonderful discussion we just heard, and please join me in giving a virtual round of applause to all of our panelists and our moderator. Thank you very much. As health leaders in Chicago, we know too well the complexities of containing the spread of COVID-19. What struck me most about this conversation is we heard clearly we were caught off guard and we rallied as a community, and we need to continue to do so. There's clearly much work ahead of us, but we are all interconnected and we will best emerge from this pandemic together. We hope that you found this information helpful to carry you through the rest of your week. Please keep an eye out for Executive Club websites for more upcoming virtual programs. In particular, we hope you can join us on December 9th for a discussion about diversifying the technology talent pipeline with the Business Technology Forum. You can sign up at www.executivesclub.org. We hope you have a wonderful rest of the day, and thank you again for joining us, and we'll see you soon. Take care, and happy Thanksgiving.
Thank you.